Welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, September 27th, 2021. Today is the third podcast in our three-part miniseries on placenta accreta. Last week and 2 weeks ago, Brett Einerson and I talked about placenta accreta, and today I'm joined by Professor Ilan Timor to talk about cesarean scar pregnancy, which is a precursor to placenta accreta. It's a huge honor to have Dr. Timor on the podcast today. Ilan is one of the pioneers of ultrasound in pregnancy and gynecology, and he's literally world-renowned. I'm very privileged to know him and have an opportunity to interview him about this fascinating topic. Next week, as a reminder, we start our 6-part miniseries on twins. All right, I want to give you all a heads up that Thursday we have a unique high-risk birth story. For the first time, we're going to be hearing from someone who decided to terminate a pregnancy. Whether you consider yourself pro-choice, or pro-life, or you find yourself somewhere in the middle, I highly recommend you check out the podcast Thursday. No agenda for the podcast, just a very compelling story. For now, enjoy my talk with Dr. Timor on cesarean scar pregnancy. Thanks for listening. Have a great day. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. All right, Dr. Ilan Timor, welcome to the podcast. It is so great to see you and to have you here in person.
Thank you so much. I hope that I will do well because this is my first podcast.
Excellent.
Should I say that?
Is it? No. We have a lot of first-timers here. When you say it's your first podcast, you mean recording or even listening?
No, recording.
Okay, so you're a podcast listener. You're ahead of the curve. It's a very big pleasure to see you, but it's also an honor for our listeners. Dr. Timor Ilan is, without hyperbole, one of the world leaders in ultrasound, specifically for pregnancy and gynecology, pioneered the imaging. You've authored, as you told me, you're on your 9th book, 318 plus articles, scientific articles. So it's a great honor to have you here. How you doing today?
Well, first of all, thank you for having me and leave out the big honor. It's an honor to chat with you in the COVID kind of era where we have very few opportunities to do that. I'm happy to be here.
We see each other from time to time, whether it's socially, academically, and we were at Andre's house for the barbecue. And we saw each other and I said, oh my God, you got to come on the podcast. And we downloaded it and picked a date and it just worked out great. And so this is amazing. So for our listeners, just because they might not know who you are, what your story is. So just give us a brief intro, where you're from, how'd you get into medicine? How'd you end up in ultrasound specifically?
Well, I used to say, when this question comes up, I used to say you don't have enough time to listen. But yes, I was born in Hungary, grew up in Transylvania, which is part of Romania, still is. And in 1960, emigrated to Israel, spent there a very long time, went to the Hebrew University in Jerusalem, and then my residency in Haifa, Rambam Hospital. And then I went to do some fellowship in maternal fetal medicine in Cleveland, Ohio.
So your residency was in OBGYN, right?
My residency was in OBGYN.
Right. And when you did the fellowship, that must have been the very beginnings of MFM fellowships in general, right?
Well, it was not even called an MFM fellowship at that time. My chairman, who will come later in the picture, really was one of the grounding members of the maternal fetal medicine arena.
Right.
And so I spent there 3 years doing wonderful time, learning what is to be here in America and part of the system, and did research mostly in fetal, would you believe it, fetal behavior. So we looked at the little wiggles of the electronic monitoring of the fetal heart and tried to read into it of what kind of sleep state the fetus is, because at that time that was big. And wrote with my co-fellow, who is still my one of my best friends lives in Cleveland still. We wrote about 6 articles about fetal behavioral states, fetal movements, fetal hiccups, all these things. And then I went back to Israel and spent there for about 6 or more years, and then came back to the States to the same person, same chairperson, who at this time was already running the department at Columbia Presbyterian. And I spent with him another couple of years. He unfortunately passed because of Lou Gehrig's disease. But this was basically the time when I decided that it would be nice to stay in the United States, even though I tried to go back for another year or so. But then I came back to Columbia Presbyterian, and from there to NYU in 1999, January 1st. And that's the story.
And when did you get interested for the first time in ultrasound?
Okay, that's a parallel story. When I was in residency, I did 1 year of electronic engineering at Israeli Technion. And my subject was to construct a miniature oxygen electrode for the scalp of the fetus. And at that time, I met somebody there who was interested also in ultrasound. And then we got the first ultrasound machine, which I already knew about in Cleveland, because I already operated an ultrasound machine in 1978 in Cleveland. So I was interested, and I bought one of the first machines in Israel and used it in the department. And then I bought another one for my private practice.
And then at the time, you're talking about, late 70s. What was ultrasound like back then?
Well, ultrasound was basically a free arm scanner that went back and forth on the abdomen of the fetus. It was called mostly B-scan, and a picture was constructed by transducer producing faint echoes on the screen, and it was a guesswork. And we were happy if we were correct.
To see what ultrasound is like now, where it's like sticking your head inside and looking with your eyes, or even better compared to then. I mean, what's that like? Because you were there at the start, you're there now, you're busy in ultrasound the entire time. So you're talking, this is 40 plus years in ultrasound. What? Looking back on that, what's it been like?
It's an amazing journey, because ultrasound basically it's a parallel kind of pathway, transabdominal ultrasound, and then derivative of this, which is the transvaginal ultrasound, that started out basically with, not with me, with Alfred Kratochwil in Austria, in Vienna. But he had a static scanner which produced pictures very, very similar to those of the abdominal ultrasound. And the electronic technology was not very good at that time. So when I went back to Israel, I stole a pediatric cardio transducer, which was the smallest footprint. But it had a very high resolution. And this is already in the internet. That's how I did my first transvaginal probe. I put 2 tongue depressors and taped it onto the handle of this tiny cardiac transducer, put a condom on it, and put it in the vagina. And that is where I was stunned, what you can see when you put the transducer close to the ovary and the uterus. That's my aha moment of embracing transvaginal ultrasound. And ever since, I never left it for 20 years until it was really accepted in the United States. And exactly 20 years.
Wow.
The editors of journals were skeptical. They said it's only an observation. There is no data. There is no...
What data? You put it in, you look. This is a good picture.
and then I wrote the first transvaginal ultrasound book. It was in 89. And then the second edition, that was in 90. And that's how it started with me in terms of using the transvaginal ultrasound.
It's amazing. Because of your history and who you are and what you do, there's obviously so many topics we can talk about related to ultrasound in medicine and in OBGYN. But I thought that we would talk today about a really interesting topic, and it's a little bit new on the horizon in terms of diagnosis and therapies, and it's something you've been involved with a lot, we've been involved with together, and it's cesarean scar pregnancy, or cesarean scar ectopic it's sometimes called. How would you explain to someone what that is? What is this concept?
It is basically a rather rare occurrence of a pregnancy implanted not in the right place, which is the uterine cavity. It is implanted in a faulty recess of the lower part of the uterus anteriorly, where it takes advantage of a previously performed surgery, namely the Cesarean section, which many claim that is not repaired all the way or the right way, leaving a little tiny dehiscence, or we call it niche, in which the fertilized egg gets lost, so to say, and implants, and then does all the bad things that we are then seeing after the pregnancy develops.
When was this first sort of identified in the sense that it was, named and, the terms were coined? Because I remember I was at a conference once in ultrasound, and this is a while ago, and there was someone giving a talk on ultrasound, and someone from the audience, I think it was a talk on ectopic pregnancy, which is normally when it implants in the tube. And someone asked a question of the speaker and said, "What do you think about cesarean scar ectopic?" And the speaker had never heard of it. And the speaker is an ultrasound person, and the person in the audience does ultrasound and had heard of it. I mean, there was this transition point where people didn't even know what it was. Do you remember when that happened?
As a matter of fact, that's a recurring thing from 1990 to about almost 1910. That was the question, because people were not, first of all, the cesarean sections were not that almost daily at that time. So the opportunity to have a scar pregnancy was much more rare than it is now. So people were really not sure about it. And that was also the time when it was christened or called or termed ectopic, which I now fight with a vengeance, because ectopic pregnancy is something that is or in the tube or out in the ovary or in the cervix, and does not result in a viable fetus, while cesarean scar pregnancy results, if continued, in a viable baby. So I am against calling it ectopic pregnancy. And these questions came after the first publications were around the 1990, and one of the first guys was a wonderful obstetrician who made a brilliant observation. His name is Ilan Timor from Lausanne, from Switzerland. We became very good friends, and he called it endogenous and exogenous pregnancy in the scar. He never called it ectopic. And that was one of the first observations, even though there were several papers which were published, but it was not recognized as such. Ilan Timor was the first one that really said, this is an entity, this is a bad entity, and watch out for it.
Yeah, no, I think that makes a lot of sense to separate it from the term ectopic, because for a lot of reasons, ectopic has a long, long history in obstetrics and gynecology, and doctors know what it is, nurses know what it is, other doctors know what it is, patients, some know, some don't, and everyone understands, that's a pregnancy, it's outside the uterus, it's very dangerous, it's life-threatening, you're not going to have a baby, this, that. And then this thing was called ectopic because it's sort of not in the right place, but it is in the uterus. It's just in a crevice in the uterus where it shouldn't be ideally. And so if you call it ectopic, it's not all those other things. And people also get confused in the treatments and the dangers. And so I do think that we just call it cesarean scar pregnancy for that reason, just like you mentioned. I think that does make sense. So Why is it so risky? Like, if it can have a live baby, so it's not like an ectopic in the tube, what is it about the pregnancy finding that old cesarean scar and burrowing into there? Why is that an issue?
The danger comes from two major occurrences. One, it can burrow itself so deep into the anterior wall of the myometrium. As a matter of fact, it's very thin there, and that's why it happens. That it penetrates into the area of the bladder.
Right. So it sort of bursts through the uterus.
And there are numerous articles about the ruptures of these when it really enters the area of the anterior wall and the bladder, which is covering that area of the uterus.
Mm-hmm.
The second danger comes from the fact that usually at least 80-90% of the cases it is associated with the placenta being very, very low and very vascular.
Right.
And when the placenta and this area becomes vascular, any kind of small insult will start bleeding.
Right.
So these hemorrhage, these bleed, these pregnancies, and that is the second danger.
Right. So it's the uterus rupturing, and that's before labor, right? This is earlier in pregnancy.
Earlier, in the second and third trimester.
And that itself is clearly life-threatening. And then also, even without that, the bleeding. And the pregnancies that do continue and don't have a rupture and don't have bleeding, more than 50% of the time, much higher, are going to have probably a placenta accreta, where because it's so burrowed in there, it's going to get stuck to the uterus. It's not going to peel off nicely at delivery.
Right, correct. So to explain the accreta, basically there is a layer between a normal pregnancy and the uterine wall, which one was called the fibrinoid layer of Nitabuch,
mm-hmm.
which now it's not called anymore. Eric Junio changed everything in the UK, and that layer is disrupted by the cesarean section, mm-hmm. by the incision, mm-hmm. and therefore the placenta burrows itself into the myometrium, deep into the myometrium, and then when it goes really very much through it, then that's dangerous. And we also, that we usually differentiate these kinds of placentae as very little penetration, then a little more penetration, and then full penetration. There are terms for this, which is not that important. But the ones that are really going in deep, those are the bad ones.
Yeah, and it's interesting. One of the other issues with this condition, cesarean scar, is it's hard to know that was the reason all this is going on unless you had an ultrasound very early in pregnancy and the person doing the ultrasound or reading the ultrasound knows to look for this, right? Because I'll see a lot of people who will come and they've had an ultrasound, and then I see them like, oh my God, this is like sitting in the cesarean scar. And they're like, well, my doctor didn't tell me that. I was like, well, they didn't really know. They didn't know to look for this. They didn't understand how to interpret it. They don't think of it in the same way, which is okay. They don't do ultrasound all day, but if this is missed, it could be a really dangerous pregnancy.
Well, you are so right, but it depends when the first ultrasound was done.
Yeah.
And patients who are unsuspecting, they may go to the doctor when they are only 9 or 10 weeks. They say, okay, I had a positive pregnancy test. I was always okay. I had 2 kids before. The last one was a cesarean section, and now it's fine. And then the doctor who does the first ultrasound sees the gestational sac and the embryo pretty low, but almost in the cavity, but does not look at the placenta, which is implanted in the lower anterior part, deeply going into the area of the bladder, and does not look at the vascularity of it. So reassures the patient, the pregnancy is in a good side, in a good place. But that is preventable by doing an ultrasound very, very early.
Right, because you'll see exactly where it is.
5 weeks, just after the first positive pregnancy test, if they are doing that 5-6 weeks, I think that an ultrasound would make the diagnosis. Now, we wrote an article and said every patient who had a previous cesarean section and has a new pregnancy should go for an ultrasound at 5 to 7 weeks. Now, this article was embraced and accepted in the literature, but it was an opinion article.
Right.
Because the societies, such as the Society of Maternal Fetal Medicine, the American Institute of Ultrasound in Medicine, the Radiology Society, don't endorse this. They say, oh, this is an extra scan.
Right.
It will ruin the economy of the United States.
Right.
Being facetious.
Right.
And therefore, it's not endorsed. But many already have realized this. And there is a follow-up paper that was peer-reviewed, and it is considered the real article or
original research.
Research article that was followed up, and there it is clearly said that if recognizing a scar pregnancy before 9 weeks has a less of a burden of complications than it is diagnosed after 9 weeks.
Right.
Absolutely big difference.
Yeah, and it makes a lot of sense because we're going to talk about what the options are for treatment of this. And I think that that's an important point because for, we have a lot of listeners and many of them are pregnant or will get pregnant. And since there's so many women who have cesareans in the United States and in the world, the rate of cesarean is higher, and that's its own topic. But okay, it's the truth. That's what happens. Many women are going to get pregnant who have a history of a cesarean. And it's not meant to scare them because this usually does not happen. This is a rare occurrence, but it can. And so it's something that women have to decide and say, if my doctor is not going to do an ultrasound early, maybe say, well, maybe I'm a little worried about this. Can you take a look? Can you make sure this is not going on? And they'll say, well, maybe your insurance won't cover it. So maybe I want to pay for it. People should decide for themselves, how much testing they want to do to rule out rare but very dangerous things. And there isn't a right or a wrong here, but when it's just sort of dismissed and, it's not going to be offered or anything like that. Yeah, I mean, we've seen it where if it's diagnosed too late, it's much harder to treat or not possible at all. And if it's early, as we'll talk about, you can have like a perfect outcome and everything can go okay, not so much with the pregnancy, but with the mother's life. So if someone does come to you at 5 to 7 weeks with a prior cesarean and an early pregnancy, in the ultrasound, not so much what technically do you have to do, but how easy is it for you to see this versus not? Is it usually obvious or is it subtle? I mean, what is it that you need to do in order to make this assessment to say it is a cesarean scar or it's not a cesarean scar pregnancy?
Well, if you have a vaginal probe and you put it in the right place, which, it's the anterior part of the cervix, it is impossible to miss it.
Right. If you get the right picture, it's there.
Now, there is nothing 100% in life, but it is really one of the most obvious diagnoses at 5, 6, 7 weeks.
Right.
Put together previous cesarean section, low gestational sac, cesarean scar pregnancy. There's no other diagnosis.
Right.
Okay, cervical pregnancy. I am right now rewriting the up-to-date, which was so archaic that I was really mad, and they accepted rewriting. So I am now rewriting the up-to-date.
For cesarean scar pregnancy.
Yes.
I was going to ask you about that because the current one doesn't even mention this balloon technique, which we're going to talk about. It's not even mentioned.
Right now, I am at the place where the differential diagnosis is mentioned. So what is the differential diagnosis of a scar pregnancy when you look at it? And the first one, cervical pregnancy. And then I say in the narrative there, however, in the previous cesarean delivery patient, it is almost entirely can be ruled out.
Right.
So again, take the clinical part,
right,
which is easy. Previous cesarean section,
right,
low insertion
right,
of the gestational sac, scar pregnancy.
Right.
There's no other diagnosis.
So obviously you're in favor of, for someone with a prior cesarean, having an early ultrasound in pregnancy. I'm curious what your opinion is about, do you recommend that women should have an evaluation of their scar before pregnancy, like doing a saline sonohistogram, to look at that scar? Is it full thickness? Is there a niche? Do you recommend that routinely in certain women, or is that still being determined?
Okay, we are getting very deep into this, and but this is an unbelievably good question.
This is a serious podcast. This is 60 minutes of medicine. I'm going to pound you with questions, Ilan. This is no softballs here.
I do almost 6 to 8 saline infusion sonohysterography procedures, which is putting, for the audience who listens, putting a little bit of fluid in the cavity with a very thin catheter. It's not painful, it's not dangerous. And then looking with ultrasound whether the scar is healed or not. And you alluded to the fact that sometimes that scar is not completely healed and you have a large dehiscence or niche. And the question is whether at that time you tell the patient or the referring physician or yourself, correct it before you get pregnant. I have one answer to this. The very last large ones are mostly corrected. And this is a new branch of gynecological surgery. There are surgeons who specialize in correcting this niche. I am against it. I think that if they are really very large and there is no myometrium there, yes, it is probably useful. There are articles about pregnancies with corrected niches or without corrected niches, and the chance of getting pregnant into that niche are basically unknown. Basically, it's unknown. And I always say, you replace, with this repair of the niche, you replace an old scar with a new scar. And then the pathophysiology or the reason for this implantation, which is today discussed much in the literature, really has absolutely no value, because you cannot predict in which pregnancies it will implant in the scar or it will not.
Yeah, we've had a hard time with that also, man. We don't routinely do saline sonohistograms on people just because they had a prior cesarean.
Correct.
People have had multiple cesareans and this and uterine ruptures, and they're coming to us for a consultation to evaluate, should I get pregnant, should I not? Sometimes it depends on the situation. Sometimes we'll look, sometimes we don't. And then it's the same thing. You, as we say, you have to daven over it. You get this image and you see how much is left of the, if the full thickness is, let's say, 10 millimeters or 1 centimeter. And you see that she has it sort of like chewed out, that she has like 4 millimeters left. You're like, okay, what's my cutoff? Is 4 okay? Is 3 okay? Is 2 okay? Yeah, no one knows. And we tell her, we don't know. And we've had situations where people did get surgery, people didn't. We've had people got surgery and then they come back 6 months later and the uterus looks perfect. And we had people who had surgery and they come back 6 months later and the uterus looks exactly the same. And so it's hard. This is an area that hopefully will sort out over the next, several years, but it is very interesting.
Can I make a comment here?
You can do whatever you want.
I think
the mic is yours.
I think that this issue has to be addressed not by looking at the niche and repairing it or not repairing it, letting the patient be pregnant or not. It is how you suture the uterus after a cesarean section. And there is now starts to be a very good literature on the fact that if you do an endometrial-free closure of the incision of the cesarean section, then there is no niche remaining, or the niche is so small that it's hardly seen. And therefore, this may be the primary thing that we have to concentrate on, and not to repair a niche that's already there.
So prevent rather than treat.
There are now at least 2 or 3 articles, and one of my colleagues at NYU is into this. We have already 2 articles put in the literature, the difference between the appearance of this niche when you close it correctly and when you don't.
It's so interesting. So let's talk about treatments. You find someone who pregnant prior cesarean, You diagnose her with a cesarean scar pregnancy. We're going to finish by talking about the technique you developed with the balloons. What were the older techniques that you knew about or tried or people have done? Like, what are the treatments that have been proposed?
First of all, when a patient comes, you have to really first make sure that you explain based on all what you have and the knowledge, the literature, the experience of previous cases. You have to talk to the patient whether she wants to continue or not.
Right.
If the patient wants to continue and accepts the fact that may be complications, then you just manage the pregnancy with a lot of caution.
Yeah.
And you do that every single day in your practice, so you can talk about this much better than I can. If the patient decides that she doesn't want to take, or this is a pregnancy that was not planned, or she doesn't want to take the risk of this, then we talk about what to do. And that is gestational age dependent. And again, I have to tell you that there are very few papers in the professional literature, our literature, that hinges the treatment to the gestational age. Because it's totally different what you do at 6 weeks and what you do at 12 weeks.
Right.
And in between.
Right.
So again, at this point, and you asked what did I do? I started out by injecting these scar pregnancies or by transvaginal ultrasound guidance or by transabdominal ultrasound guidance. And that was my go-to technique.
Right. With something like either potassium or methotrexate or something to stop the pregnancy.
Usually I inject methotrexate. My best friends who do that every day in Boston, for instance, Peter Dubillet, excellent person. He swears KCL.
Right.
I don't think there is a difference because basically the damage is almost done by the mechanical insertion of the needle.
Right.
And I used to joke and say, you can inject also whiskey. It will do the same.
Right.
But indeed, the local injection is the first one that I tried, and I got pretty good at it.
The injection, just for our listeners, is you're using ultrasound and you're guiding a needle either through the mom's belly or through the vagina into the pregnancy. And then you inject something that's intended to stop the growth of the pregnancy, and then it stops developing and eventually, either withers down or miscarries out. There's still risk, obviously, of bleeding afterwards, but if the pregnancy stopped, the blood flow will decrease, the hormones are going to decrease. It'll sort of, go sort of past the hump and on the way down in terms of growth.
Absolutely correct.
That's done. That's a treatment that's known. It's cervical pregnancies have been treated this way. I mean, there are other conditions, so it's a technique that was already there that you just applied to this.
Exactly.
Similar. Okay, so that was the first thing you did.
Then the other thing is that many swear, and there are countless articles of just injecting systemic methotrexate. That means that you take the methotrexate, which acts on the placenta, and inject it intramuscularly in the buttock of the patient.
To the mom, right. It's like a chemotherapy sort of, and it sort of kills the pregnancy through her bloodstream.
And many swear that that helps. I am totally against it.
Right.
I use methotrexate with every single scar pregnancy, but only as an adjuvant.
Right.
Systemically.
Right. And the reason people would try that is because methotrexate's been used for ectopic pregnancies and used with great success, with 80%, based on the circumstance. So they thought it would work for this. But why do you think it doesn't work as well for this compared to one in the tube?
I have my own view, which is unsubstantiated.
You're the only one I'm interviewing today. You can give me your view.
I think that when the placenta implants in a place that is not hostile, but it's not friendly. Plus, you give the methotrexate, it may act upon the scar pregnancy. But these pregnancies are usually much, much more viable than an ectopic pregnancy.
Right, because they have the uterus supplying it. Yeah.
The placenta is more resilient to the methotrexate.
Yeah.
And my dislike of systemic methotrexate, no matter how you use it,
Right.
one injection or subsequent injections, the two kinds of treatments, I think that, in my view, at least 50% it did not work.
Yeah.
But that you find out only after a week.
Yeah.
And then
it's a week
the
bigger.
pregnancy is already bigger.
Yeah.
The vasculature is bigger. The complications are bigger. And the route of termination is more complex. And
right.
So here is what I do. Yes, you have a scar pregnancy. Are you sure you want to terminate it? Give me an answer not later than tomorrow. But tomorrow, I need an answer.
Right, because it's
not more than tomorrow. Because if you give it to me, like if there is a weekend in between, there is already a pregnancy that's 5 days bigger.
Yeah.
And my job will be harder to terminate it, and you will have more complications.
Right. And sometimes this leads to treatments like major surgery to like resect it and sew the uterus together. I mean, that's a huge operation potentially, and that could also lead to, serious issues for future pregnancies.
Yes. So the surgical excision can be done from within the uterus by looking at the area and then manipulating the excision under direct vision, but from the inside. Hysteroscopically. And then the other one is to open up or go into the abdomen of the patient or robotically or whatever, peel off the placenta, the bladder, and then do the excision and repair it. Those who do this, it's very interesting. They swear that this is the way to go because you don't leave a niche.
Right.
And I agree with that in many ways. I have a friend in Argentina, one of the best placental acrita surgeons. His name is Jose Palacios Jaraquemada. Wonderful man. He does only excisions. Only. I respect him, but I always tell him, why would you do that at a 5, 6, 7, 8, 9 weeks pregnancy? We have less invasive ways to do it.
Right. So tell us about the technique that you studied, you developed with the double balloon, because that's the one that we use now. We think it's terrific.
That was basically invented without being aware of it by a Chinese guy who placed a balloon in the uterine cavity. But that was a larger pregnancy. So then I started to put in single Foley balloons after I injected it locally, but it started to bleed. And my balloon was not to terminate the pregnancy, but to stop the bleeding.
Right.
And then I said to myself, wait a minute, let's use the balloon to compress the pregnancy.
Right.
And if it's small, it will cut off the blood supply. So then I started to use the single balloon.
Right.
And we published 18 cases with 2 Italian friends of mine who started to use it also. And then 3 patients expelled the balloon because the uterus does not tolerate anything inside.
Right.
That's why we have abortions. The uterus expels the content. The single balloon popped out.
Right.
So then I said, wait a minute, how do we do to retain that balloon? So I worked a lot in the labor and delivery room with the double balloons before my present career. And I did put in the double balloon, and the upper balloon is the anchor balloon that keeps in the whole system, and the lower balloon does the job.
Right. So just to explain this visually, right? So there's a pregnancy in the uterus. It's growing very low in the uterus towards the cervix and up towards 12 o'clock inside the scar. And the thought is, if we can put a little thing inside the uterus and then inflate it like a balloon, it's going to compress that pregnancy, for lack of a better word, smush it, and it'll, compress the blood flow. It'll sort of smush the pregnancy. It'll stop the pregnancy from growing, and it's no incisions, no injections. It's just there. And then that's the lower balloon. And then there's like a balloon on top. It looks like it's like a double balloon On top looks like a peanut almost. And the top one sits in the top of the uterus to hold it in, and the bottom one compresses it. And, it goes in, there's no anesthesia required. It's really, it's tolerated. It's not horrifically painful for people. And then you leave it in for what, overnight, typically?
It varies. It depends on what day of the week I'm doing it.
Okay.
If I do it on a regular, like beginning of the week, I usually keep it in for like 2 days.
Mm-hmm.
If I do it Friday, I keep it until Monday.
Yeah, so 2 to 3 days, yeah.
But it's very interesting that I did many of these, and I even shortened the time. I put it in at 8 o'clock. Mm-hmm. At 12 o'clock, I deflated the lower balloon under ultrasound, and there was no more heartbeat.
Yeah.
Then I deflated the upper balloon also, not extracting the catheter. Yeah. And at 5 o'clock, took another look. No bleeding, no heartbeats. I took out but I became aware of the fact that it may not coagulate all the vessels.
Right.
And some of these patients had a little more bleeding. Mm-hmm. So I kept it in 2 days and sometimes even 3 days. And then when you take it out, then all the vessels are already closed.
Right.
And there is no source of bleeding. So I think that now I don't go for the 1 day like extraction.
Right. So it's an amazing technique. It's like when you see one or do one, it's like it's the simplest concept. It makes so much sense. It's such a high level of working, such low morbidity. Why hasn't this taken off more? Why do you think?
Let me, before I answer this question, you said before that no anesthesia is required. Usually the only one, sometimes the patients are sensitive.
Sure.
And in these patients, I do use a little bit of a local anesthetic
in the cervix. Okay, that's fair.
So that's just to cut into that sentence of yours. So it's interesting. We had a webinar about 3 months ago. The Europeans did it, and I talked about balloons. And this question came up. Why do people not embrace it? So there are many reasons. One, I don't have the balloons. Mm-hmm. So my answer in the slide was cook, balloon number so-and-so, cost that much.
Right.
Okay. Number two, I have never worked in the labor and delivery. I don't know how to use it. My answer, go up to the labor and delivery. If your place uses it, take a look at it. If your place doesn't use it, there are many articles on the subject.
Right.
Number three, I cannot use it in the office because I'm afraid that something happens. My answer, do it in the operating room, do it in the office, put the patient in for an overnight or some hours to look at it. So there are answers to every excuse, so to say, but these are legal excuses of people who don't yet know the procedure. And I think that if people would do a little bit of an effort, people would use it. Right now, there is a registry. Mm-hmm. Mm-hmm. And people upload cases. And we started by uploading cases. Now there are more than 350 cases in, not all balloons,
right,
but a large number of balloons, because in Poland they do it, in Switzerland they do it. I have friends in Texas, known people who are in the Akrita business, and they are doing it. In Italy, they are doing it. So there are lots of cases. So that's the way that people learn how to really try to do it.
Yes, we went online. The website is www.csp-registry.com. Welcome to the Cesarean Scar Pregnancy Registry. So there's information on it, steering committee centers, project sponsors, resources. Is there a video here of the balloon technique?
I don't think so.
Oh, all right. We're going to have to put that up on our website. We're going to get that video because I know you have it. I have some good ones.
I have one.
We'll put that up on the website. for people to see.
So it's managed in the UK.
Okay.
And there are 3 people who manage it. One is Baski Tagilanathan, and Andrea Kalin, who was my research assistant for many years, and myself.
Amazing stuff. Full circle. From the early days of the machine where you can barely tell someone's pregnant to now you're seeing someone at 6 weeks, diagnosing something potentially, counseling them, maybe continuing the pregnancy, knowing to watch for these complications, maybe ending the pregnancy in a safe way. It must be pretty satisfying to take it full circle like that.
It is. And again, we always say it's rare, but and yes, it's nowadays the cesarean section rate stabilized, right? 32 point
whatever,
some of the change percent. And yes, it is rare, but it is a serious. I think that the breakthrough of realizing the importance is when the connection between scar pregnancy and placenta accreta spectrum was made.
Right.
Probably my biggest pride is that I have 2 articles in which I said at the very beginning that scar pregnancies are baby accretas.
Right.
And the second one, even more important, that I gave products of the pregnancy, of scar pregnancy and of placenta accreta to 2 pathologists. And I said, put it under your microscope. Tell me which one is which.
Right.
And they couldn't.
Right. The same thing.
That means that the histology is even the same.
Right.
So that, I think, focused the attention towards an early diagnosis, and the fact that if you don't treat or you don't want to treat or you miss to treat, it develops into something much more consequential.
Ilan, thank you so much for coming on the podcast and sharing your story and this really important information about cesarean scar pregnancies.
Of course. Thank you for having me. It was a pleasure ventilating.
Great. Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.